Everyone, what's up? Welcome back to another session of our free NCLEX review sessions. We are on the 56 out of the 90 days, and we are welcoming everyone to join us today with our lecture on the spinal cord injury topic. And for those who are new to the channel, you're also welcome to join with us all throughout the session. And we are also encouraging you to enroll to our NCLEX program. Our course is available at www.stancoastnclexcoaching.com, and we have updated the video library that we have for the on-demand lectures and also the animated video series. Plus, we have the 3,000 NCLEX questions on top of the 200 NGN test questions, and these are all accessible to you for the entire 6 months. And we are encouraging you to check on the description box below. We have the information, so kindly do that in order to know more about us. And we are also encouraging you to like and subscribe our channel and make sure that you're sharing this with your friends who are also reviewing for the NCLEX. Now let's get started today. Good morning, Anita. Let me see who's in the room today. All right, looks like we have about 18 viewers right now. So if you don't mind, kindly like our session today once we are completing our review. All right, so let's get started into our topic today, and this is all about spinal cord injury. We're going to talk about the incidents, the causes, the pathophysiology, and the treatment, and also the assessment findings. That's very important, especially we need to differentiate between the manifestations and yeah, there are different severities, different areas of damages that we should know about so we can tell which exactly the injury is going. And now we also need to tackle onto the nursing care after we have completed all those. All right, so what is spinal cord injury? Well, basically this is the damage to the bundle of the nerves and also the nerve fibers that sense and receive the signals from the brain. And the injury of the spinal cord or to the spinal cord, it's either partial or it could be full or complete, let's say, and they can interrupt the nerve pathways and also the conduction of these neuro messages into the other nerve cells, right? So again, don't forget about the partial or complete. And the spinal cord here will probably undergo some bruising or let's say contusion, or maybe cuts, or maybe some form of pressure into the spinal cord. And when this is going to happen, our worry really is on the swelling of the spinal cord. This is a big deal, wherein it can lead to the tissue death. The cells in the spinal cord will become necrotic. They're eventually going to die, and this is going to follow because of the poor blood flow and also the poor circulation to the spinal cord. Whenever there is a compression, let's say there's a significant injury to the vertebrae, then this can cause low blood supply into the spinal cord itself, which is going to lead to the tissue death. Now, when this happens, when there is going to be tissue death, of course, what you're going to expect here is that the patient will end up with loss of movement, and also their sensation will be greatly affected. The reflexes will be so impaired, and the person here will have issues in the control of their bladder and also their bowel function. And let's take a look real quick about the causes of the SCI, or the spinal cord injury. And most often, this is going to be caused by the vehicular accidents, could be falls, sports, work accidents maybe, and it could be brought by, let's say, stabbing or gunshot. Now, what are those things that we need to really keep in mind, especially during the immediate phase? This is something that you should really think about, especially in the NCLEX. And the majority of the questions here will gear towards asking you on what primary complications that you need to watch for. Well, of course, You're going to have to worry about the breathing, the air, the breathing, especially if there is an involvement in the C3, C4, C5 part of the spinal cord. You really need to worry about the respiratory failure that can result to this patient, right? Now, let's talk about autonomic dysreflexia. This is another common condition in as a complication to the SCI. This is a common question wherein you're going to be asked what to do exactly when the patient will end up with the autonomic dysreflexia. You might be asked what to do if the patient will complain about that severe headache. What you're going to do if they're going to complain about the there's goosebumps when they have that, when they're feeling something is not right with them. So what are you going to do first? So let's tackle on that one as well. And one of the major complications here is also the spinal shock. And this can happen during the acute phase of the spinal cord injury. Now, take a look here into the photo. You'll see here the different levels of the vertebrae. You have the C1 to 7, of course. We have the thoracic spine from T1 to T12. We got the lumbar spine from L1 to L5, and got the sacral and the coccyx levels as well. So we're going to talk more about this once we go to the different levels. Now, also, we're going to have to identify those very common sites where the spinal cord injury is. And these are the following. Mostly in the neck region, these are the known levels, C5, C6, C7. And also in the mid-back region, T12. And also the lower back region. And most of these information actually is based on the incidence of spinal cord injury due to motor vehicular accidents and stuff. Mostly this is going to happen through those kind of accidents. So we'll talk this time about the transection. What is the transection? This is probably going to come out in your exam. So this is basically going to tell us the severity or the area where the damage is going to happen. All right. So it can be split into two. There is what we call as complete transection of the cord. It simply means that the spinal cord is entirely cut. There is a severe damage. This is going to lead to a complete loss of your patient's sensation and also their movement, the motor function, and their reflexes will also be greatly impaired this time. Again, we're talking about the complete transection. This is going to cause a spinal cord cut. All right. Now, let's talk about the second one, which is the partial transection. What is this? Well, this is going to involve the partial damage of the spinal cord. And this is going to allow some kind of retention in the patient's sensation and also their motor function, and especially during or especially below the injury site. Okay, so there will be some retention of their sensation and also the motor function. So here, in the partial transection, the individuals here, or the patient, will have that minimal sensation. It's not really a complete loss, but they will still feel some heat or maybe pain or any kind of untoward sensations. They will still have those. Now, the patient with a partial transection will have a higher potential for recovery. And also the patient will recover early if this is going to be, the patient is getting the immediate attention. They will get the medical treatment as early as possible in order to prevent further damage to the spinal cord. Now, let's talk about the different areas, and we have the different spinal cord syndromes, and we are referring this to the partial type of damage. Okay, this time we're going to talk more about the partial transection, and there are 6 of them. Let's have the central cord syndrome. So what is this basically? Well, this is a condition wherein the patient has an injury to the central point of the spinal cord. So let's talk about this one, central cord syndrome. So where exactly is the damage? Well, again, this is affecting the central portion of the spinal cord, right? And this is an area where it contains the nerve fibers that will carry the signals from the brain to the various parts of the body, and those that will also relay the signals back to the brain. So again, we're talking about the central portion of the spinal cord injury. So you will see here in the photo about the varying levels or the sensation. So you'll see here the red portion, which is basically going to tell us that there is impaired motor function. And it is characterized by loss of motor function in the upper extremity. Please take note of that. So where you're seeing the red color, the motor function is impaired, affecting the upper extremities. Whereas the lower extremities, the motor function is somewhat preserved. And the sensation here, as you see with that light pink color, look at that right there, below or mid trunk of the body and towards the lower parts of the body. Here, the sensation, let's say for example, the sense of touch, sense of pain, also their sense of temperature, may be largely intact around this time. And it's mildly affected. So they will still have some sensation, really, as I've said. But it can vary from one person to the next. But again, there is still retention of the sensation in this person with a central cord. Now, again, what's the reason why they're going to have this alteration in the motor function? As we know that the central region of the spinal cord is involved in controlling the movements of the arms, right? Again, the central region of the spinal cord is involved in the movement of the arms. So when this area is damaged, then the person will have a pronounced weakness or paralysis of the upper body. Whereas the lower extremities are less affected because the nerve fibers here controlling the leg movements are located more peripherally in the spinal cord. Now, if you're going to ask, what are the common causes of the central cord syndrome? Well, this is often seen in the older adults, especially with the cervical spinal cord injury. Again, spinal cord, cervical level. Frequently resulting from a fall or maybe a whiplash injury when they are driving their car maybe and there's a sudden break or something like that. Or, especially when there is an extensive vehicular accident in the highway. And so this will lead to the hyperextension of the neck, really affecting the cervical spinal cord. Now let's talk into the next, again, reviewing the central cord syndrome. It's going to affect the motor function, specifically the upper extremity, as you see here with the red section. And then as far as the sensation, it will be varied, but the patient here will still have retained sensation for the pain, temperature, and also, as we are going to talk into the next one, anterior cord syndrome. So what is this? Well, this is caused by the damage to the front part of the spinal cord. So take a look into this one right here. The front part of the spinal cord is damaged. That is why it's called as anterior cord syndrome. Now, if you're going to ask, what would be the effect into the motor function of our patient? Well, the patient will end up with a motor loss, and especially below the level of injury, meaning the paralysis or the significant weakness that they will experience will happen in the parts of the body below the injury site. Now, if you're going to ask about the sensation, well, they will have the ability to sense pain, also the temperature. But again, this is going to be lost below the level of injury. Again, the patient will have loss of motor function, but there's also a degree of pain and temperature sensation loss. Okay, now let's have the other sections of the body here. Even if the patient will have loss of sensation, there is going to be still the ability to sense the vibration, also sense of light touch. These are going to be preserved because, as we know, that the dorsal, which is basically the backside of the spinal cord, carry these sensory signals. I'm talking about the sense of vibration, position, and touch. So again, the dorsal columns of the spinal cord will carry these signals, and of course, they're located at the back part of the spinal cord. And so that is why they will still be able to have the sense of position, the vibration, and touch. Now let's move forward to the next part of our spinal cord syndromes. There's another one. We have the posterior cord syndrome. So what is this? The damage is brought into the posterior portion of the gray and the white matter. And so as we are going to look into the cross section of the spinal cord, look into here, it is going to involve damage into the back portion of the spinal cord, especially the white and the gray matter, which will contain those nerve cells, nerve bodies. And for the white matter, they're going to contain the nerve fibers that carry the signals. Now, what are you going to expect in a patient that has the posterior cord syndrome? Well, their motor function will still remain intact. Again, take note of the posterior cord. Their motor function will be intact, and the reason for that is the motor pathways actually will run through the front. Remember about this one right here? The front side is not affected. And the pathways actually will run through the front and the lateral parts of the spinal cord. And this is not the affected portion of the injury. Okay? So if you're going to ask this time about the sensation, there's going to be loss of the vibratory sense, also loss of the crude touch, and also their sense of position. And again, the patient will have inability to feel the vibrations. They're going to be having difficulty sensing rough or light touch. And the patient here will also have the inability to sense the position of the body. There's going to be issues with balance and coordination this time. So take a look here into the white spot, okay, which is the anterior view. So the patient here will have normal motor function, as you see in the front side of the body, right? But if you're going to take a look into the sensation, especially, take a look into the widespread loss of the vibratory sense, this pink area right here, and also they have that loss of sense of position. Again, this will cause them with issues of their instability. Their gait is going to be problematic this time. Now, as we're going to go to the next one, this is what we call as a Brown-Sequard syndrome. So what is this basically? Well, the patient will have an alteration in their motor function. So basically, the patient will have a damage into one side of the body. So let's take a look into this picture right here. All right. So again, the damage is caused by the penetrating injuries. It could be a stab wound, or it could be a gunshot wound or a gunshot. But also it can cause with tumors, maybe ischemia, or maybe some other conditions that could affect just one side of the spinal cord. Now, this is what we call as the ipsilateral. So if the patient has the injury to that particular side of the spinal cord, then they're going to end up with the loss of motor function on the same side. Okay, take a look right here. Loss of motor function on the same side of the body if they have that injury into that particular side of the spinal cord as well. So again, the motor function is going to be lost on the same side because the corticospinal tracts, which control the movement, are disrupted around this time. Now, take a look into the sense of vibration this time. This is also going to be lost. Their sense of body position will also be lost this time because of the damage to the dorsal columns, which is right here. right? And the patient will have an impairment in their sense of deep touch. So this is something that would really complicate, especially when they are not able to feel the discomfort when they've been laying in bed in the same position for many hours. So they're going to be prone to developing those decubitus ulcers. Now take note here in the Brown-Séquard syndrome, there is what we call as the opposite side or contralateral manifestation. So what do you think are the symptoms here? Well, regarding the patient's sensation, they will have inability, they will have loss in sensing pain. Also, the temperature will not be sensed by this patient. And actually, the sensation here will be on the exact opposite side. I mean, the impairment of the sensation rather is on the opposite side. So for example, if the injury is onto the right side of the body, wherein the motor function is going to be impaired, however, the patient's sensation is going to be affected on the exact opposite side, on the left side. So again, we're talking about the loss of pain, the loss of the sense in their temperature, and also, and the reason for that is because the spinothalamic tracts are actually carrying the sensation, which is crossing to the opposite side shortly after entering into the spinal cord. So this is why the Brown-Séquard syndrome has this contralateral impairment in the sensation. So for example, if the injury is into the left side, so let's reverse this. If the injury is happening into the left side of the spinal cord, well, the impairment of the motor function will be on the left side. However, there's going to be a impairment of the sensation onto the opposite side. Now let's move on into another problem in the partial transection, which is the Conus medullaris syndrome. So what is this? This is characterized by damage, especially when the lower part of the spinal cord is injured, okay? Or it is specifically injuring the lumbar nerve roots or the conus medullaris. And when we are having this type of patient, the bowel and the bladder function will be impaired this time because it will affect the nerve that control the bladder, the bowel, and also the legs. So we will expect that the patient's lower extremities this time will be flaccid, okay? And so when we're taking care of this patient, you will find this patient really have difficulty in controlling their bladder, their bowel, and also the movement in their lower extremities. They are gonna remain flaccid, okay? So here we have the bulbospongiosis spongiosis reflex. So what is this? There's going to be limitation in the damage, especially if the effect is on the upper sacral of the spinal cord. There's going to be some kind of a reflex that will still be retained around this time, which is basically the patient can still maintain some penile erection. Okay, that's because it is retained, especially if the damage is only in the upper sacral segment. There was also there's also a micturition reflex, which is basically that reflex that control the urination, right? And so if the damage is only limited in the upper sacral segment, they will still remain to have that function. They will still be able to control their urination. So please take note of that. The micturition reflex and the bulbospongiosis reflex will be intact if the damage is only affecting the upper sacral segment. Okay. So take a look here in the photo. Again, when the patient's damage is caused into, or if the damage is directed into the lumbar or the nerve roots or the conus medullaris, then you will see that the patient will have flaccidity into the lower extremities and also the areflexia of the bowel and the bladder. Now let's talk about the last one, which is the cauda equina syndrome. This is the damage into the nerve roots, which are located at the very bottom of the spinal cord. Now, as we know that these nerves will control the bladder, the lower parts of the body, the intestines, the bowel, and also the legs. All right. So we have here our patient's placidity into the lower extremities. They will have decreased reflexes, especially in the lower parts of the body, including the legs, and it will make their muscles very weak and floppy this time. So take a look right here. They have areflexia into the bowel and the bladder. And again, there is a reduction or loss of reflexes into the lower parts of the body, including the legs. Okay, cauda equina. Now let's talk about the different levels of the spinal cord injury this time. And most in the NCLEX, you will be asked into determining what would be the priority nursing action that you should be doing, especially if the injury is more onto the cervical spine. Okay, but we will have to subdivide these areas because they have different effects according to the levels of the spinal cord. We need to specify this time. Now let's talk about the C1 to C5 injury. So here you're going to expect the person will have quadriplegia. All four extremities will be paralyzed. Or this is simply known now as the tetraplegia, which is the newer term for that. Tetraplegia. And we also have the acute respiratory failure, especially that the phrenic nerve is that nerve that will innervate the respiratory muscles. Remember, this can severely impact the vital functions, and especially in the breathing. And also we know that with a specific C4 injury, let's just talk about the C4. This is going to be innervated by the diaphragm. Basically is going to be affected here. And again, it is connected to the phrenic nerve, which controls the diaphragm. And so if the C4 is injured, or maybe the C3, C5, this can really cause the respiratory paralysis. Anything above the C4, okay, if the injury is targeted more above the C4 level, it can really lead to more of the paralysis in their breathing, okay, and also the tetraplegia, again, or the quadriplegia. Take note about these two. Now, if we're going to talk about C5 to C8, somewhere here, C5, C8, then you're going to be worried more on the movement, okay? There is still going to be a limitation in their respiratory capacity. Their coughing reflex will be very weak. There's going to be some shoulder movement around this time. Now, as we're going to have to talk about the other sections right here, C7 to C8, there's going to be paralysis of the hands and also the legs. And take a look into the injury into the C6, C7. So there is specification here, especially with the paralysis. The legs and the trunk will be paralyzed. And there's also a specific paralysis into the wrists. All right. Now for the C8 to T1, or the thoracic one, our patient will have paralysis into the trunk area and also into the legs. And our patient's fingers and hands will be weak as well. I mean, the tone of their muscle will be severely weak this time. Now, focusing into the T levels, okay, please take note. We are on the thoracic this time. You really need to pay attention into the loss of the movement and sensation. Depending on where the injury is along the thoracic spine, there's going to be loss of movement, also a loss of sensation in the chest, the trunk. There's also decrease in the function of the bowel and bladder, and simply the legs as well. Now here, as you're going to take a look into the T2, T4 levels, there will be paralysis of both the trunk area and also the legs. Take note of that. Paralysis of the lower extremities and also the trunk. But take note into the sensation. There's going to be a lack of sensation below the nipple line. All right. Now, if we're going to talk about the T5 to T8 levels, this is still going to manifest the paralysis of the lower extremities and also the trunk area or the chest, the abdominal area. And the sensation here will be lost below the rib cage. All right. Now, if you are going to be worried about the T9 to T11, there's also paralysis of the lower extremities. It's always going to be there. But the sensation here will be lost below the navel area or below the umbilical area. Now, if you're going to be worried about T11 or lumbar 1, again, there's going to be paralysis, loss of sensation into the lower extremities, especially the hips or the legs. And then we also have the lumbar up until sacral 2. This is going to cause weakness, numbness in the legs. And we have the S3, S5 levels. Basically, our patient will have varying degrees of sensation, and especially with the sacral levels. Let's talk about the sacral level ranging from S2 to S3. So what do you think will be the impairment? Especially that when the injury is focused or targeted to this area, the nerves on these levels are actually controlling the bladder function. And so if the person has injury to these levels or below these levels, okay, below S2, S3, the bladder can contract, but won't be able to empty completely. Okay, please take note of that. If the injury happens between S2, S3, there's still going to be contraction of the bladder, but they will not be able to empty the bladder completely. There is contraction, but no emptying. Okay, no complete emptying of the bladder. And this is what we refer to as the neurogenic bladder, which is basically one of the most common complications of spinal cord injury. Now, if you're going to be asked about the sexual function of the person, especially if the injury is above the sacral 2, above sacral 2, and if you're going to be asking the NCLEX about the sexual function, well, the person here, especially the male, can still be allowed to have some penile erections, but there's no ejaculation. Right? Penile erection, but no ejaculation. And the reason for that, it's because of the damage to the sympathetic nerves. Again, they will be having penile erections for the male, but no ejaculation. Now, what about the injury between S2 and S4? Let's talk about that. Between S2 and S4. What do you think if the injuries will occur into these areas? Well, it can damage both the sympathetic and also the parasympathetic responses. And so the patient will no longer be able to have penile erection and no ejaculation. Both will be gone. No erection, no ejaculation this time. Again, if we're talking about injury between S2 and S4 levels. Now, to wrap this up, I just want to make sure and emphasize this, that most often the areas where the NCLEX is going to ask you is about the cervical injuries. C2 to C3, this is going to be very fatal because of the respiratory compromise. And then same with the C4. And please don't forget about the tetraplegia, right? Or the quadriplegia. It's going to happen somewhere in the injuries between C1 to C5. Now, specifically C4, this is going to be greatly affected. Our patient will have respiratory failure because of its innervation with the phrenic nerve, which actually control the diaphragm. All right. And then we have the thoracic injuries from T1 to T12. Don't forget about the paraplegia. Okay. T1 to T12, there's going to be paraplegia. And the sensation will be varied according to the specific levels this time. All right. And don't forget about the S levels. Remember about those different impairments, especially S2, S3, or above S2, or let's say impairment between these levels S2 and S4. So take note of those, because some of those test questions will be about patients asking about their sexual ability, right? Now let's go take note into the different complications of the spinal cord injury. As you see, there's a long list. And I highlighted those very common ones in red: spinal shock, respiratory arrest, pneumonia, atelectasis, and autonomic dysreflexia. And these are what you're going to pay attention during the acute period, okay? Acute phase, immediately when the injury has occurred. So these are the commonly asked questions in the NCLEX. Acute phase. Now, let's talk about the spinal shock. What is going on here? Well, the patient will have a transient condition wherein the person will have temporary loss of all reflexes. Take note of that. Spinal shock. This is going to cause them temporary loss of all reflexes. All right, so what's going on here? Reflexes. It also includes the loss of motor function, loss of sensory function, and also the autonomic activity below the level of injury. So bladder control, bowel control, also the erections, impotence, those kinds of things. Okay, autonomic activity below the injury. So now, what do you think would be the duration of the spinal shock? How long will this affect the patient? Well, the duration, as based on to the statistics, or even in the medical books, medicine books, the duration basically can last from few hours to several weeks. Few hours to several weeks. Please take note of the duration of the spinal shock. All right. Again, there's a problem in their reflexes. There's going to be loss in the reflexes, loss of motor function, loss of sensory function, and also the autonomic activity control below the level of the injury. Again, below the level of the injury. Now this time, let's focus onto the respiratory arrest. What do you think would be the priority here? Respiratory arrest, pneumonia, atelectasis. This is going to happen because of, again, the possibility, impairment, or injury above the C4, or let's say the C4 levels. And again, the function of the diaphragm here, which is the respiratory muscle, is innervated by the phrenic nerve, which controls the movement. And again, the patient here will be prone to developing the other complications, such as the lung collapse or the pneumonia, because of the weakened respiratory muscles. They are no longer be able to expand their lungs properly, and they will be prone to the aspiration pneumonia with infection. Okay. Another is cardiac arrest. I don't really see the cardiac arrest questions related to the spinal cord injury in the NCLEX textbooks or reviewers. I don't see a lot of those test questions, but let's tackle anyway. So what's in here? Well, of course, the initial trauma to the spinal cord can cause significant cardiovascular instability, right? And this will also exacerbate the spinal cord edema. Spinal cord edema, which can also worsen the initial injury, right? And it will also happen along with the other injuries. And so these factors can also affect the cardiac function and potentially will lead to the cardiac arrest. Now, another set of complications here is the thromboembolic complications. I haven't read way so much. I haven't seen any more questions regarding the thromboembolic complications in the reviewers. Not so much. But here, we are going to still pay attention to our patient to develop these blood clots because of their immobility and also in the sluggishness in their blood flow and the circulation. This will really increase the patient's risk to developing the DVT, okay? And also the pulmonary embolism. But we're still going to have to monitor and treat this patient to prevent these from happening. Now, it's shown in the studies that about 15% of patients who have spinal cord injury will lead into the DVT and the PE. And that is why we need to really be careful, make sure that we are preventing the patient to develop the DVT and PE. There's so many interventions that we can do for that, okay? Now, others would be infection. They are going to be susceptible to this because of the immobility. There's compromise in immune function, or maybe because of the presence of those indwelling devices like Foley catheter, okay? Indwelling devices because of the, let's say, catheter, urinary catheter, Foley cath, or maybe centraline. These are known to be the entry points of the infection. All right. Now let's talk about autonomic dysfunction. What constitutes the autonomic dysfunction or dysreflexia? Well, this one right here, dysreflexia. This is another common situation wherein you're going to be asking the NCLEX. And the person here is going to be affected because of the lesion above the T6, which is characterized by an exaggerated autonomic response. Again, the level T6 or above T6. Take note about the autonomic dysreflexia. And so here, the person will have exaggerated autonomic responses to stimuli below the level of injury. Take note of that. Exaggerated autonomic response. So we'll find out what this is exactly. Exaggerated autonomic responses. Well, what are those responses that we usually will see in the NCLEX? Well, one of those is the severe hypertension, HTN. They will end up with the bradycardia. What else? There's many more, okay? But we'll focus on these two. Severe hypertension, which is around above 200 in the systolic, or could be the diastolic will be above 120, 130, 150. It's a hypertensive crisis that will occur in this patient. Now, what do you think can trigger the autonomic dysreflexia? Okay, again, these are going to be aggravated by one of the following. The precipitating factors that can trigger the autonomic dysreflexia will be 1, bladder distension. You're correct, Mary. If the patient's bladder is full, or let's say half full, yeah, this can trigger the autonomic dysreflexia. They will have high blood pressure, not just 150 over 150 over 80, but this is going to be hypertensive crisis. No kidding. It can lead to stroke. All right. What else? Urinary tract infections. Yeah. Or it could be bladder stones, or maybe overfilled obstructed catheter. Even if the patient has a Foley catheter, but if the drainage tube is somewhat sluggish, yes, that can also precipitate the autonomic dysreflexia. Let me put that right here. Obstructed Foley tubing. Okay? Or let's say the bag has been full already. It's not causing proper outflow of the urine because the bag is already full. Obstructed Foley or overfilled urine bag. Another thing that can precipitate, let me put them somewhere here that is clear for your view. Let's have the next precipitating factor, bowel issues. If the patient will have fecal impaction, constipation, that's another aggravating factor. Fecal impaction. If you're going to administer enema, yeah, it can precipitate. So this is contraindicated in the patient with autonomic dysreflexia. It can lead to this condition. Okay, what else? Pressure ulcers can also aggravate. So if they've been in the same position more than 2 hours, they've been sitting for a while, they haven't been repositioned while they're sitting on the wheelchair, or let's say they've been laying on the recliner for more than 2 hours, this is actually going to precipitate the autonomic dysreflexia as well. Okay, pressure ulcer and what do you call this? Immobility or prolonged same position. Again, that is going to aggravate that. In some cases, sexual activity can also precipitate the autonomic dysreflexia. Stimulation can sometimes do that if there's any form of discomfort or irritation. What else? Temperature extremes. Please take note of the regulation of the temperature in the patient's room. If it's too cold, yeah, it can lead to the hypertensive crisis. If it's too warm, the same thing can happen. All right, because they have dysregulation in their autonomic nervous system function. Whether it's hot or cold, this can lead to the autonomic dysreflexia. Again, those are many things that you need to pay attention in the NCLEX, guys. All right, another is pain, prolonged sitting, tight clothing. So please take note of what they're wearing. Could be other physical irritations. This can precipitate the autonomic dysreflexia. All righty. Now, other than the dysreflexia, we have the autonomic dysfunction. So what are those things that you will anticipate in this patient with autonomic dysfunction, which is very specific to that? Well, the patient will have orthostatic hypotension. Drop in the blood pressure when they are standing, if they still are able to stand. They will have difficulty in maintaining temperature. Thermoregulation impairment. That's another one. And again, this is caused by the dysfunction of the autonomic nerve pathways. Now, urologic issues, what are those? Well, it's going to be about the neurogenic bladder, wherein there's damage into the that specific side of the spinal cord. It can lead to high bladder storage pressures, and this can also deteriorate the renal function. Okay. Now we also have the paralytic ileus. This is a condition wherein the patient will have cessation rather in the motility of their bowels, and this is going to be seen in patients with acute or subacute spinal cord injury. And again, this is caused by the autonomic dysfunction. There's also the heterotopic class ossification rather. This is the abnormal growth of the bones in the soft tissues below the level of the injury. and this is going to occur within a few months after they sustain the spinal cord injury. There's also the syringomyelia, which is basically the formation of the fluid-filled cyst within the spinal cord, and this can occur within months or years after the injury. And when this happens, the fluid-filled cyst can actually expand, and it will damage the spinal cord tissues and will lead into other neurological deficits. Well, of course, we have depression because of the psychological impact of the paralysis. We also have pressure ulcers because of the immobility, the spasticity, amenorrhea, of course. This is going to be a temporary, not really a permanent amenorrhea, but a temporary one. And of course, this is related to the stress of the injury, which will cause the imbalances in the hormonal regulation and also the physical inactivity. And lastly, we have the neuropathic type of pain, and this is caused by the damage of the nervous system, which will occur in about 34 to 94% of patients. 34 to about 94 patients with SCI. Okay, so you will be dealing a patient that has a history of spinal cord injury. You're going to be noticing that they might be taking a whole lot of pain medication because of the burning, tingling sensation. There's going to be stabbing pain, which is going to be very difficult to manage. And again, don't expect that all these patients with spinal cord injury will have loss of sensation. No. Recall into the different levels, so you will understand really that there is going to be preservation of some sensations in these patients. Now, this time we're going to talk about the diagnostic test, and as you see here listed are the following: the CT of the spine, the MRI, and the reason that they're going to be helpful is to detect the fractures, the vertebra that will be impinging into the spinal cord. It will check also the dislocation or any other bony injuries. Now, in the context of the CAT scan of the spine, this is going to really pay attention, or will take a look into the vertebral fractures, dislocation. Now, for the MRI, this will determine, it will show those soft tissue structures, okay? Will identify soft tissue contusions. All right, specifically the spinal cord, and it will also detect the hemorrhage, maybe bleeding within or around the spinal cord. Could be the swelling of the spinal cord. This is also going to detect that spinal cord swelling, and also the bony injury, and also the development of that fluid-filled mass that can happen within 6 months or several years. This is going to develop in this condition as well. So take note of that. Electrophysiologic monitoring. So what is this? This is going to involve the use of the somatosensory evoked potentials, MEPs, and they're going to assess the neural pathways, and it will measure the electrical activity in response to the stimuli as well. And the urodynamic studies, what are these? They are going to be done to evaluate the bladder function and can identify issues, maybe the bladder outlet obstruction, or it can possibly check on the contractility of the bladder, okay? Neurogenic bladder. It will evaluate the ability of the bladder to contract itself, or can it completely empty? So this is the test that will definitely measure that one. Now, another thing is the ultrasound of the lower extremity, or the VQ scan. These are going to be useful in detecting presence of the DVT, right? And also for a patient that has a risk to developing pulmonary embolism. Again, these two, ultrasound of the lower extremity and the VQ scan, will be helpful in determining if there's already clot formation, or maybe the lodging of the clot into the pulmonary circulation. Now this time, guys, we'll talk about the emergency care. This is going to be the highlight of the spinal cord care injury. Spinal cord injury care, rather. So what are we going to focus here? We will be looking into the airway management. Specifically, there is involvement of the cervical spinal cord. Okay, we want to make sure that the patient's cervical spine is aligned in a neutral position. Cervical spine alignment, and it should be placed in neutral position. This is one of the common questions that, or situations that you'll be asked in this patient. Now, aside from that, we need to make sure to check on the patient's airway to see if they have lots of oral secretions or maybe debris. We need to make sure that we are clearing that. Okay, clear oral secretions in order for them to prevent choking. Aspiration, that's really important. Now, another emergency care is the administration of the isotonic fluids, or could be the crystalloids. Please take note, guys. Especially if the patient will have the spinal shock. Remember about that, spinal shock. The patient will end up with a low blood pressure because of maybe the bleeding or related to the injury of the spinal cord. We really need to make sure we are monitoring their blood pressure this time. The neurogenic shock, basically it will involve administration of up to 2 liters of isotonic crystalloid fluids in order to is DVT curable? DVT, if you're pertaining to the clot itself, deep vein thrombosis, then it is going to be probably if the extents of, or if the clot size is very significant, blocking into that venous circulation, it will be removed surgically, right? It could be thrombectomy. But again, when you're talking about a patient that may have a higher risk of developing those clots, maybe they have some issues in their clotting mechanism, hypercoagulability, if they have any other factors like endothelial injury, and also their mobility is impaired, you gotta have to take a look into those several factors. And so if you're gonna ask curable, there will be preventive measures to do that, prevent. But as far as curing, these patients that are really prone to developing the DVT, okay, not just about the spinal cord injury, right? If they're really prone to developing those clots, then they need to maintain taking those anticoagulants, all right? If they are really high risk, especially if they have clotting, coagulopathies, they have that problem, then they will need to take the anticoagulants for a long term. But if you're just asking about DVT specific to the spinal cord injury, and if they don't have any other risk factors other than the immobility, then of course we can treat that. We can also administer those anticoagulants in order to reduce their risk in having the DVT and also preventing the pulmonary embolism. Now back to the emergency care, especially if the patient will end up with a neurogenic shock or the spinal shock wherein they're going to have a low blood pressure, low BP, okay? Now, if they have, AFib is another factor in the formation of the DVT. There's different groups. Remember about the HES, okay? So what will be our nursing interventions here? There's many. And one of those is the administration of the crystalloid fluids, about up to 2 liters. We want to make sure that we're going to maintain their oxygenation levels. This is huge. And we want to make sure that they probably would be needing the mechanical ventilator if they already develop the injury into that specific level, to see the C levels. So they probably would be on the ventilator right that minute. Okay, as soon as they are being intubated, they need to require the mechanical ventilator and for them to maintain pulmonary function. Now, another would be the use of the vasopressors. If there's going to be neurogenic shock or spinal shock, then the administration of the epinephrine, dopamine, will treat the hypotension, specifically the neurogenic shock. Now, another pharmacologic therapy that will be involved here will be the administration of the atropine. Why are we going to expect the atropine administration? And this is going to be indicated if there is bradycardia. All right. Now, another treatment during the emergent period, we're going to expect the administration of the plasma extenders like the dextran. This is going to treat the hypotension secondary to the spinal shock. Plasma expanders, such as the dextran. Okay, so please expect that. Again, don't forget about the atropine to treat the bradycardia. And we have more. Insertion of the nasogastric tube is also one of the nursing actions that we will be doing because of the possibility that the patient will end up with the ileus, which can complicate into bowel obstruction. To manage bowel obstruction. So there's a necessity for us to insert the nasogastric tube. And also it will, it will prevent that huge complication. Another thing that we need to be doing is to keep an eye, make sure that we are repositioning our patient every 2 hours. This is a big thing because they are going to develop the pressure sores really rapidly. So you're going to have to pad those bony prominences. You're going to have to remove the constrictive clothing, belts, items in their pockets, and take off the spine board as soon as possible, okay? Once they're getting transferred to the ED, make sure that they're off the spine board to prevent any untoward sensation, especially if they have the autonomic dysreflection. We don't want that. Now, another is to manage their airway, like I've said, or maybe the surgical decompression. So this is going to be important, especially if there is apparent injury or let's say compression of the spinal cord by the vertebra, okay? So we want to make sure we are preparing the patient for immediate surgical procedure to relieve the pressure. Yes, cervical collar, that's going to be part here. We'll put that over here. Cervical collar to neutralize the position. That's right there, okay? Cervical collar, and yeah, thank you, Mariama. Leg rolling is another technique that should be used whenever a patient has spinal cord injury. Leg rolling, moving the patient as one unit. All right. Now let's go back into the surgical decompression. What do you think about that? Again, if there is an involvement, if there is compression of the vertebra into the spinal cord, then the surgery will be required in order to prevent more injury into that level of the spinal cord. So let's move on into the next part here. What are the other nursing care progressing forwards? Our priority will always be the ABCs. Don't forget about that. Okay? ABCs. Don't forget about the ABCs, even though the patient has been dealt with already after the critical period. We're going to have to assess and keep monitoring their vital signs, their breathing pattern, their lung sounds, their motor function. The abdominal girth. This is very important. Abdominal girth. This is going to help us in detecting if there is bladder distension, which is basically right at the bottom. Bladder distension. What about the bowel sounds? Yes, that's also important, because if your patient will have hypoactive bowel sounds, then they are at risk to developing constipation. Hypoactive BS, they're known to be at a higher risk to developing constipation, and that's not a good thing, because they will probably complicate into impaction of the stools, and that's another trigger for the autonomic dysreflexia. Okay, thank you, Chichi. Now we also need to monitor the patient's temperature. I forgot to tell you about the temperature monitoring. Remember that our patient here will be prone to developing hyperthermia because of the autonomic nervous system dysregulation. Hyperthermia, a common complication. Again, our patient's vital signs should be monitored, looking into the hypotension, bradycardia. If the person will have an injury above the T6, okay, focusing on above T6. So our patient's vital signs here will be more of hypotension above T6. There's also bradycardia. And the reason for that is because of the sympathetic outflow that is being affected here above thoracic 6 level. Our patient's blood pressure will be lower than normal. They're going to be bradycardic as well. Now, another thing that we need to pay attention in the care of a patient with a spinal cord injury is to make sure, again, the placement, maintaining their cervical collar during any transfer. Cervical collar, if this is a known injury, if injured, make sure that we have that applied at all times or during any transfer. And we want to make sure that when we are moving the patient, again, we have to make sure that the patient is dealt with accordingly as a one unit. Do the log rolling to prevent any further injury to the patient. Okay, so another thing is the application of the other orthopedic devices. Let's say the cervical collar, or it could be the tongue. Okay, the traction. So these are things that we need to watch for. We need to make sure that we're looking into the alignment and also taking a look into the skin integrity of the patient. This is what we refer to as the Crutchfield tongs, or the Gardner-Well fixation device right here. Okay, so please take note, make sure that this is intact, properly worn by the patient. What else? We need to focus here. Administration of high-dose steroids, especially during the first 8 to 24 hours. This is going to reduce the edema. Okay, this is going to be helpful in reducing the edema in the spinal cord. Another thing is monitoring the patient for the spinal shock. Take note about the blood pressure, the heart rate. There's that autonomic dysreflexia. What else? The coughing and deep breathing. We need to make sure the chest physiotherapy, as applicable and as ordered by the doc, we need to also implement that. What else? Yeah, the TLSO brace. DVT prevention is another thing because of the immobility of our patient. So according to what the prescription from the doctor, it could be with the use of the anticoagulants, blood thinners. Then we're going to have to administer those, and we'll monitor for the patient's clotting studies or coagulation studies. The range of motion of exercises should be provided to our patient to prevent more atrophy of those muscles. And if the patient will have a neurogenic bladder, they will be needing the intake and output or INO catheter every 4 hours. And this is to prevent the autonomic dysreflexia as well. And then it's also emptying their bladder. We need to make sure to teach them on doing this. There are some techniques that can be helpful. Intake of fluids as well. This will prevent any, what do you call this? Retention, or let's say it will help flush the renal system to prevent urinary tract infections, right? Adequate hydration is very important. Same thing with the bowel training program. You want to make sure that they will be taking laxatives or stool softeners to prevent the impaction or constipation, also including high fiber in their diet. And we need to acidify their urine. And the reason for that is to prevent urinary tract infection as well. And it's going to vary sometimes. If a patient has other types of stones, we want to make sure that we're going to deal with the patient's diet accordingly as well. All right, let's have our first question of the day. We are on the first hour and 13 minutes. Let's have the first question. The supervising nurse is observing a novice nurse assessing a patient with a traumatic spinal cord injury for sensation. Which action by the novice nurse suggests a need for additional training? Is it A, testing for light touch before testing for pain? B, asking the patient to close their eyes during assessment? C, inquiring if the patient perceives the instrument as sharp? D, using a random pattern to test for sensation. Supposing you are the charge nurse and you are observing a new onboarded RN assessing a patient with a traumatic spinal cord injury for sensation. So what do you think would be? Which of the following scenarios will require you to take action? You need to educate further this newbie. Is it testing for light touch before testing for pain? Or is it B, asking the patient to close their eyes during the assessment? Or is it C, inquiring if the patient perceives the instrument as sharp? Or letter D, using a random pattern to test the sensation? I'm seeing letter D from Maria. Using a random pattern to test for sensation. What else? What happened to the other guys here in the room? What is your answer? Okay. In this test question, you should be selecting that option that is fundamental to testing the sensory function of our patient. Again, make sure that you recall the fundamental sensory assessment. So you should be eliminating that option or those options that will give patient clues when you are testing their sense of sensation. All right. Or, yeah, their sensation function rather. So remove those options that will give the patient clue of what you're doing to them. So let's have letter D. What is in letter D? Using a random pattern to test for sensation. Is that correct or is that an incorrect procedure? Using an irregular or random. What is that? Random pattern. This is basically one of the better techniques, especially when you're checking the sensation of our patient, because the patient will be required to respond to the actual stimuli, and they should not be able to predict the next location to be tested. Okay, this is a good technique. All right, why it is a good technique? The patient will be they will have less chances in predicting the next location to be tested. All right. Patient will not be able to predict the next testing location. All right. All righty. So it should be random. Do not let them feel like, hey, I got this. I think I can fool my nurse this time because I know the pattern. They're touching my face on the right side, and then they're touching my left side, and then they're going to touch my back of the head. And then the same thing with the neck. Your pattern is so predictable this time. So make sure that you're going to have to be skillful enough. Make sure that you are allowing chances, or not allowing the patient to have that ability to predict where they can expect the testing to be done. I'm a little confused about wording of C. Inquiring if the patient perceives the instrument as sharp. So this is basically asking the patient, hey, do you think this is sharp? Or maybe in another testing, do you feel this as a light touch, or do you feel the cotton ball touching your skin? So basically here, you are already giving them a clue. The word sharp is already a clue for them. So do not give them any clues at all. All right? Do not give them any clue. Do you feel this as a warm sensation, or is this cold? No. Do not give them clues when you are testing their sensation. Writing down here, don't give any clues as far as the temperature, the dullness of the object that you are applying, or the softness, or the sensation of pain. Okay? Do not give them the clue. So the correct answer here is basically letter C. Do not give them any clue words when you are asking them. Rather, you would ask them as, what do you feel when I'm using this object to your skin? Can you tell me the temperature? Can you tell me what sensation you are feeling right now while touching you with this object? Do not give them any clues. So if you answered letter A, B, testing for light touch before testing for pain, yeah, that's another technique that we can do. So we're eliminating that because what we are looking for are those actions done by the new nurse that will require teaching, additional teaching. All right. What about letter B? Asking the patient to close their eyes during the assessment. Yeah, you need to tell them that in order to decrease their chances of peeking, right? Or kind of blindfold them. That would be good as well. So that is something that we should be eliminating. All right. Again, you should be testing your patient accurately what they are feeling by not giving them any clues, and make sure that your testing site, the location, will be unpredictable. All right. So they will not know exactly where you are touching. Especially if you are going to ask them, can you tell me what extremity I am touching right now? And if you are touching the left leg and then they're blindfolded, they will not be really going to cheat on you if they're not going to be seeing you touching that particular extremity. All right? So make sure that your assessment is accurate. Do not give any suggestions to the patient. That is very important. Knowledge is good. Thank you. Very good. Thank you, patients. Let's have number 2. Upon admission, which assessment should be prioritized for a client with a spinal cord transection at cervical 7? Select all that apply. Upon admission, which assessments should be prioritized for a client with a spinal cord transection at C7? Select all that apply. Is it A, reflexes, B, bladder function, C, blood pressure, D, temperature, E, respirations? Upon admission, Which assessment should be prioritized for a client with a spinal cord transection at level 7, C7? Okay. While I'm waiting for your answers, let me try to eliminate stuff here. Let's have letter E. What is in letter E? Respirations. What do you think about respirations? Is this a critical assessment in level C7? I'm seeing Anita answering B, C, D, E. B, C, D, E. Let's take a look on respirations. Remember that the patient will have a possibility, or there is going to be an effect onto the intercostal muscles, which is needed in the respiratory function. C7, intercostal muscle involvement. So you should be assessing the respiratory pattern, making sure that there is no respiratory compromise. And it's because of the intercostal muscle involvement. So that is one of the answers. What about the letter D? Temperature. Will that be needed? Do you think this is a part of the assessment, temperature checking? Of course. You need to do the temperature checking, as we know that the body can lose its ability to regulate the temperature due to the spinal shock. Loss of thermoregulation. Thermoregulation related to the spinal shock. Regulation related to the spinal shock. What about the blood pressure? Is the blood pressure going to be a priority assessment, you think? Blood pressure. Blood pressure, which is letter C. Of course, it is going to be necessary, as we are going to anticipate spinal shock because of the severe hypotension. Related to hypotension, you need to have that baseline assessment as well. What about bladder function? Letter B. Will that be important as well? Do you think this is going to be a priority? Should be prioritized. Going back into the question. We know that bladder function is very important, right? It is significant. But especially that we are going to deal with the life-threatening issues, do you think that bladder function would be necessary during the acute phase? I don't think so. This is something that we can deal with after we have cleared all the other assessments, okay? So this will be in secondary priority. So we're going to mark this. All right. Again, I'm not saying that we should not be worried about this. Yes, we will. Significant, but not life-threatening. We are dealing with more critical issues this time. Should be prioritized. What about reflexes? Are we supposed to be doing that, especially during the acute phase? Like immediately as a priority? Do you think that would be part? Same thing. With letter B, this is also going to be a significant assessment, but not a priority upon the immediate phase. Significant, but not priority. Okay. Guys, especially when you are in the immediate phase, when you are receiving the patient, like fresh admission, your goal really is to address those life-threatening issues. And if you're going to delay in assessing those much more critical assessments. If you're going to take more time in assessing the less priority issues, you're actually delaying delivering those crucial nursing interventions. Again, this test question is testing you to prioritize, especially during the acute phase. You have to deal with the ABCs. Again, we're looking into the respirations, the regulation of the temperature, circulation, that's part of it, and the blood pressure. Never forget to prioritize those things. All right? The others can wait. You need to deal with the more pressing issues, because if you're going to do all these things all at once, then basically you are not providing the immediate care because you are doing something else. Instead, you're supposed to do this because you need to deal with the spinal shock, delivering the IV fluids or vasopressors. And if you're doing something else, then definitely you are delaying the care. You're harming the patient. Let's have number 3. A female patient with pneumonia and a history of neurogenic bladder is being admitted. What should the nurse do first? Is it A, inquire about the patient's usual urinary patterns and bladder control measures? Is it B, assist the patient to the toilet at scheduled times? C, check for urinary incontinence every 2 hours. D, perform intermittent catheterization on a set schedule. Now, you have a female patient with pneumonia and history of neurogenic bladder is being admitted. Okay, what should the nurse do first? Will you do A? Will you do B? Or are you going to do C or D? Okay. Being admitted. So this is a brand new patient, and you probably are not familiar with the overall physiologic function of this patient. So, a brand new patient being admitted. Neurogenic bladder, a history of neurogenic bladder. So this is already known. It could be that the patient has had existing medical records in the system, but this is a patient that is being admitted. Your information is not only about the history, but you need to also inquire on the patient's current state. So what would be that? Well, the correct answer here is to inquire about the patient's usual urinary patterns and bladder control measures. All right, make sure that you do that first. Make sure you do the assessment of their bladder patterns and how they're going to control their bladder in order that you can individualize the care plan. Okay, so that is the correct answer. If you answered letter B, assist the patient to the toilet at scheduled times, this is something that can take place if you have already known the patient's bladder control, if you have known their practices, their urinary patterns, again, will follow. Can be done if the RN has completed letter A. All right. The same thing for letter D. Perform intermittent catheterization on a set schedule. You need to assess first, investigate first the current status of our patient. What do they do at home? So make sure you do the assessment first. All right. And of course, you're not just going to depend on the medical history or whatever records that is available in the system. You still need to ask the patient, what are they doing at home to empty their bladder? What about letter C? Check for urinary incontinence every hours. This is something that would be much more appropriate if we are dealing with skin integrity. But again, this should follow after the initial assessment. Okay? Make sure you do your initial assessment, as we know that patient is a new admission. Again, don't forget the thorough assessment in our patient so you can establish the plan and also implement the interventions. All right. What about number 4? When planning to move a patient with a possible spinal cord injury, what instructions should the nurse give the team? Is it A, wrap the arms next to the body to limit movement? B, move the patient gently to minimize pain? C, immobilize head and neck to prevent further injury? D, use pillows to cushion the back for comfort. What is your answer here? When planning to move a patient with a possible spinal cord injury, what instructions should the nurse give to the team? Is it A, wrap the arms next to the body to limit movement? I really don't know what that is. B, move the patient gently to minimize pain. C, immobilize the head and neck to prevent further injury. And D, use pillows to cushion the back for comfort. We don't have any other correct answer but letter C. All right. Letter C. We need to immobilize the head and neck to prevent further injury. There's nothing else. Make sure that you have that collar, okay, in place. Make sure that it is secure. Immobilize the site. If you had answered letter D, use pillows, will that stabilize the patient's head or neck? Nope. If you are going to apply cushion, this will cause further injury. It should be kept in a neutral position. Will not maintain neutral position. Okay. Our goal here is to make sure that the spine is in a neutral position. What about here? Move the patient gently to minimize pain. Will that ensure the safe transport? Move the patient gently to minimize. Well, here when we are dealing with letter B, move the patient gently to minimize pain. The pain management is something that we can address at a later time after the transfer, but not during the transfer, okay? What about letter A? Wrap the arms next to the body. Well, it's not really critical. It's not going to immobilize the head and neck in the transfer. So we're eliminating those steps that will not secure the patient's neck and the head. We want to remove those distractors. Anything that cannot promote safety to the neck and the head area, then we're going to have to eliminate those items. Let's have number 5. A patient with a spinal cord injury reports blurred vision and has a blood pressure of 205/104. What is the nurse's first action? Is it A, turn off the lights and reduce environmental stimuli? B, position the patient on their left side? C, assess the bladder for distension? C, or D rather, administer pain medication? So your patient here has an SCI, but now is reporting blurred vision and a high blood pressure, 205/104. What will be your first action? Is it turning the lights off? Is it positioning the patient on their left side? Or checking the bladder for distension? Or D, administer pain medication? Yeah, remember about the autonomic dysreflexia. Any distension of the bladder can contribute to that. It can precipitate the autonomic dysreflexia. That is our correct answer. Autonomic dysreflexia. Okay. Then again, this is going to trigger the patient's hypertensive crisis. So you need to carefully assess what is going on. Check if the bladder is full. If you are doing letter A, turning off the lights, it can help, but not going to treat the bladder distension. The bladder distension is one of the top causative or contributing factors in this condition. All right. What about letter B? Position the patient on their left side. It doesn't really address the autonomic dysreflexia. It's not specific intervention. Okay. Removing that one. Letter D, administer pain medication. You think it can help? It's not going to treat the autonomic dysreflexia at all. Not indicated. It hasn't been known to reduce the incidence of autonomic dysreflexia. Never. All right. So again, guys, make sure that you recall the concept of the autonomic dysreflexia in a patient. Recall those manifestations and the interventions that you should be implementing. All right. Let's have number 6. A patient with a neck fracture at C6 is admitted to the ICU. Which findings suggest neurogenic shock? Is it A, involuntary and spastic movement, B, hypotension and warm extremities, C, hyperactive reflexes below the injury, and D, absence of sensation or movement below the injury? A patient with a neck fracture at C6 is admitted to the ICU. Which findings suggest neurogenic shock? Will that be A, B, C, or D? Our clue right here is the neurogenic shock. All right, let me try to eliminate things. Let's have letter D first. What's in letter D? Absence of sensation or movement below the injury. It is indicating spinal cord injury, but does not specifically identify neurogenic shock. Not specific to neurogenic shock. I mean, I'm talking about the manifestation. It will not specifically help in the diagnosis of a neurogenic shock. This one, absence of sensations, very vague. Okay. What about letter C? Hyperactive reflexes below the injury. Hyperactive reflexes before the injury. It actually does not occur during the acute phase of spinal cord injury. Remember about the spinal shock? There will be a decrease in the reflexes. Acute period. No hyperactive reflexes. So this is wrong. We are eliminating letter C because in the acute period, remember that it can last for days up to weeks. So you will not be eliciting the reflexes, hyperactive reflexes this time. What about letter B? Hypotension and warm extremities. Hypotension and warm extremities. Remember that the neurogenic shock is basically the drop in their blood pressure. Yeah. Neurogenic shock. There is going to be what? Low blood pressure. There's going to be low heart rate. What else? Vasodilation. And that is why warm extremities is present, because of the vasodilation. Warm extremities. That is the correct answer. If you're answering letter A, we know that during the early phase of neurogenic shock, there's no spasticity. Okay? No spasticity during the early phase of neurogenic shock or in the acute period of the injury, spinal cord injury. There's none of that. So again, focus into the clue: shock, neurogenic shock. And I've discussed this back in the lecture about shock. Remember about the neurogenic distributive shock? Our patient will have massive vasodilation. That's why they're going to end up with the warm extremity and also the low heart rate and the low blood pressure. Okay, let's have number 7. What is the highest priority nursing action for a patient admitted 16 hours ago with a C5 spinal cord injury? Is it cardiac monitoring for bradycardia? Is it B, respiratory rate and effort assessment? Or C, administration of low molecular weight heparin? Or D, applying pneumatic compression device to the legs? 16 hours ago with a C5 spinal cord injury. Highest priority nursing action. Yeah, that's right, Josephine. Whoops. We know that's already 16 hours right after the injury. And we have our patient C5 spinal cord injury. So what would be the highest priority in this patient? Priority nursing action. If you're going to think about the cervical spinal cord, cervical spine, always think of this as your main priority, which is letter B. Nothing else. Respiratory rate and effort assessment. Okay, so your patient is 16 hours post SCIs, right? Post SCI. This can evolve. This patient's edema in the spinal cord can progress. Edema in spinal cord. It can probably affect the other levels. So whenever there is an extension of the edema, it can also damage the other levels of the cervical spine. It will, or spinal cord rather, it will damage, causing an impairment into much more respiratory issues, right? Our patient's effort of breathing and their respiratory rate. This is huge. If you answered letter A, cardiac monitoring for bradycardia, it is important, but not as important compared to our airway. Again, A, B, C's. Follow that sequence. Important, but not as urgent compared to respiratory function. Letter C, administration of low molecular weight heparin. This is also significant nursing action to prevent the DVT. But if you are going to deal with airway, that should take priority. What about letter D, applying pneumatic compression device? This is another good intervention. Prevention of DVT. Deep vein thrombosis, same thing with this. DVT prevention. But it will not take precedence to letter B. Again, airway is our priority. Number 8. A nurse is attending to a patient with a spinal cord injury who is complaining of a severe headache and experiencing heavy sweating. The patient's vital signs show a blood pressure of 240 over 120 and an apical rate of 54 beats per minute. What should be the nurse's first action? Is it A, inspect the skin for irritation or pressure? B, elevate the client to a sitting position? C, check the urinary catheter for blockage? D, administer antihypertensive medication? Ooh. Look at this. These are actually all good interventions. But which of the following would be the most critical step that will be done by the nurse to prevent further complications of the autonomic dysreflexia. I know these are all important nursing interventions, but what would be that first step? Okay? What would be that first step that can relieve or that can at least temporarily treat the patient while you're going to get back to the medication room and get that antihypertensive medication? Yeah, our best answer here is to elevate the client to a sitting position. This is our primary nursing action this time when you have a patient that has the autonomic dysreflexia. Okay? Our patient is at risk for developing CVA this time. Okay? Yes. The hypertensive crisis will make them at a high risk to CVA. The first action should be to elevate the head of the bed because this can lower the blood pressure secondary to postural. It can actually drain the blood flow. Okay? Drains blood by gravity. Okay? So there will be less venous return. So this will diminish the blood pressure. That would be our initial action. And then after that, we're going to do the other nursing actions. It could be checking the patient's urinary catheter for any blockage, or it could be checking the skin for irritation for pressure, and then you're going to have to administer the antihypertensive medication as well. Okay? Spinal cord injury. Yes, with a spinal cord injury, the autonomic dysreflexia can do this complication, hypertensive crisis. We can elevate the head of the bed. Yeah, we can. So, our administration of antihypertensive medication is going to be helpful. However, we need to decrease the venous blood return. This will significantly treat that as well, but it will not be definitive. Yep, sitting position. Yep, and as we know that the spinal cord injury is basically not limited to just one level. There are so many, okay? We can put them in a sitting position as a one unit. Alrighty. This is a common question, guys, in autonomic dysreflexia. Alrighty, let's have number 9. A client with a cervical spine injury from 24 hours ago has several prescriptions. Which one should the nurse clarify with the provider? Is it A, anticoagulant, B, plasma expanders, C, H2 receptor blocker, D, muscle relaxant? What do you think? A client with a cervical spine injury from 24 hours ago has several prescriptions. Which one should the nurse clarify with the provider? Is it anticoagulant? Is it plasma expanders? Is it C, H2 receptor blockers? D, muscle relaxants? As long as we are keeping the neck in a neutral position with the cervical collar, that we can put in a sitting position. Yeah, we are not prevented from sitting the patient position if they have a cervical injury. Again, that's not going to limit. Our goal here when we are repositioning here is to make sure that they are placed in a neutral position. Okay? So that doesn't prevent them from actually sitting. All right? So what do you think about this one? What would be that medication that you should question? Especially in this acute phase. cervical spine injury from 24 hours. So which prescription that you should clarify? Let's have letter A. What do you think about letter A? Do you think that this is contraindicated in this patient? 24 hours ago, has several prescriptions. Take note, guys, when the patient has been in the clinical setting, acute care, 24 hours past the injury, they're already cleared, right? They are already cleared. Diagnostic tests have been already carried out. So if there is an order for an anticoagulant, this is intended to prevent thromboembolism, DVT. And if there is no contraindication, then why not administer? We are not going to question this one. Prevention of DVT. What about plasma expanders? Will plasma expanders going to be needed this time? If the patient still has the low blood pressure, the spinal shock, the low blood pressures, they're going to be unstable around this time, we probably would still be administering the plasma expanders to treat the hypotension. Expect that we still be doing this one as well. Now, what about the H2 receptor blockers? Cimetidine, famotidine. What do you think about these medications? Are they indicated? Yes, they're going to prevent ulcers. And there is no contraindication this time for this medication. What about letter D? Muscle relaxants. We don't have any other choice. Why would you question this prescription, especially within this period? Supposing this is the 25th hour or 26th hour, and you got this order about the muscle relaxant. Why would you question? Well, we know that the patient that has the spinal cord injury, remember that this spinal shock, I mentioned this early in our manifestations. We know that the spinal shock can happen within few days to about several weeks, right? This can have that long duration, several weeks. And of course, the average duration, amazing. There's an average duration of about 1 to 6 weeks, or 1 to 6 days rather. 1 to 6 days. Or it can be shorter. But guys, when we are looking into the muscle relaxant, what do you expect in our patient? Do you think that the patient is spastic around this time? No. They are not going to require the muscle relaxants because the reflexes below the level of injury are actually not there. They will have flaccid paralysis. Okay, so they're not going to need the muscle relaxant this time. All right, that's the reason why you should question the order, because it's not going to be needed yet this time. All right, it's not specific if it's a PRN or a routine medication, right? And so we will consider this as a medication that is going to be routinely ordered or given to our patient. So we shouldn't question this because, again, in spinal shock, the duration is going to last for several days. It could be several weeks, and the patient does not manifest the spasms around this time yet. They're going to have the flaccid paralysis, also loss of sensation. However, though, they might have restoration. There might be return of their reflexes gradually, but again, it will not be expected around the earlier stages. Within the week, you're not going to expect this to occur. So again, back to our muscle relaxant. So again, your strategy here is to recall the manifestation. When exactly the duration can last for this patient with a spinal cord injury, especially the spinal shock. All right. Recall about the duration. So you will know when to exactly administer these drugs. Let's have number 10. After 1 month of treatment, a patient at spinal shock starts to feel muscle spasms in their legs and excitedly informs the nurse about the leg movement. Which response from the nurse would be the most accurate? Is it A, this suggests the nerves are healing? Or is it B, keep trying to move all affected muscles? Or is it C, you might be able to walk again? And D, these are reflex movements not controlled by the brain. Again, guys, I'm inviting you to enroll to our NCLEX course at www.stancoast-NCLEXcoaching.com, and also check on the description box below, reminding you to sign up so you will enjoy our course. We have updated our library of on-demand videos plus the animated video series, and also our resources, our audiobooks, the flip books that you can access for the entire 6 months. So what would be your answer here, guys? Question number 10. Your patient is excited, telling the nurse that they are feeling the muscle spasms. And he is excited because of the leg movement. So what would be the correct answer here? The correct answer, or the correct response by the nurse to the patient, would be letter D. These are reflex movements not controlled by the brain. So this is going to occur because of the increased sensitivity of the lower motor neurons post the spinal shock, but they are not controlled by the brain. So this is not really gonna be an indicator that their paralysis, the motor impairment, is going to be restored. It's not going to be a assurance that their movement is going to be restored. Again, the reason, it's because of the increasing sensitivity. Remember that there is a resolution. There was going to be a comeback of the reflexes this time after several weeks. So take note of that, guys. This is not something that would be an indicator that their motor function will return. It isn't. It doesn't suggest that the nerves are healing. No, it is because the spinal shock has resolved. Okay, what about letter B? Keep trying to move all affected muscles. If you are going to tell the patient about keep trying to move all muscles, this is giving them, the patient, the false hope that they might end up with recovery of the motor function. False hope. Again, false hope. There is no recovery of the nerves. You might be able to walk again, all the more suggesting unrealistic expectation. Again, the reason why the patient is feeling those spasm, it's because of the comeback of the reflexes. And these are not controlled by expectation. These are not controlled by the brain itself. All right? If the brain would tell the leg, hey, I want you to flex right now, it will not do anything. Okay? Expectation. All righty. Let's have number 11. A client with a spinal cord injury asked the nurse why the dietitian recommended lowering their daily calcium intake. What is the nurse's most accurate response? Is it A, consuming a lot of dairy can cause constipation more often? B, staying immobile boosts the amount of calcium your body absorbs from food? C, not putting weight on your bones causes them to lose minerals? And D, eating dairy products could result in weight gain. your patient with a spinal cord injury asking why the dietitian lowered their daily calcium intake or recommended to lower their calcium requirement. So what would be your response this time? Will that be A, B, C, or D? Let me have letter A first. Consuming a lot of dairy can cause constipation more often. Yeah, it can lead to the constipation, but this is not the main reason why the dietitian recommended a low calcium diet. Not the primary reason. It's not about the constipation. Let's have letter B. Staying immobile boosts the amount of calcium your body absorbs from food. Will it? No, there's not going to be increased calcium absorption from the intestines. Actually, the patient's immobility can lead to release of calcium from the bones. Immobility can cause what? Bone resorption. Wherein the bone is going to end up demineralizing. This will allow release of calcium from the bones to the blood. Okay, so the patient here will end up with a temporary hypercalcemia, right? An elevation of the calcium in the bloodstream. And remember, when there is abundance of calcium in the blood, this will be filtered by the kidneys. And so the patient will be at a higher risk to developing calcium stones. All right. So that's the reason why the patient has a low calcium requirement, or the dietitian will be lowering their calcium intake this time because of the inadvertent hypercalcemia. Okay, so the correct answer here is not putting weight on your bones can cause them to lose minerals. If the patient is going to be staying in bed or immobile for a longer period, if there's not going to be an activity, then they're going to develop the bone resorption. That is the correct answer. Letter C. What about letter D? Eating dairy products could result in weight gain. Is there truth in that? No, they're not going to necessarily cause weight gain. They are not typically restricted solely for that reason. Okay? Again, the main reason why the calcium intake for this patient is somewhat reduced is because of the risk of bone demineralization caused by the immobility. It can lead to the hypercalcemia and eventually will lead to the calcium stones. All right. So it's not really like lowering like low, but you're also not increasing, just the regular intake of calcium, daily requirement. All right. Our answer is letter C. Let's have number 12. How should the nurse explain the effects of a T2 spinal cord transection injury to the patient? Is it A, your shoulder movements will be restricted, or B, you will retain full use of your arms, C, you might lose complete respiratory function, or D, it's common to experience a fast heart rate? We're talking about the effects of a thoracic 2 spinal cord injury. Will that be A, your shoulder movements will be restricted, B, you will retain full use of your arms, C, you might lose complete respiratory function, and D, it's common to experience a fast heart rate? T2, thoracic 2 level. Let me eliminate options. If you had answered letter D, it's common to experience a fast heart rate. No. If you have this patient that have a T2 spinal cord injury, it's not going to be a fast heart rate, but rather bradycardia, not tachycardia. And the reason for the bradycardia is the autonomic dysregulation caused by autonomic dysregulation. Autonomic dysregulation. Now, let's have letter C. You might lose complete respiratory function. Is this something that we will be worried in a T2? No. We know that we are going to worry about the respiratory function when the injury is occurring at the cervical level, particularly above the C4. All right? Nope. Instead, we worry about respiratory function whenever there is injury to above C4 level. Okay? Worry about the respiratory function. What about letter B? You will retain full use of your arms. Yeah. What do you think about that? Letter B. There's actually no impairment here, especially with spinal cord injury T2 level. It will preserve full motor and sensory functions of the arms. This is preserved. Okay? Preserved in T2. They should not be worried about any motor function or, let's say, sensory function in the T2. Okay? They will have full use of the arms. So letter A is going to be a wrong answer as well. Your shoulder movement will be restricted. Like I've said, there is no motor and sensory impairment in this level. Okay. Answer is letter B. So recall, guys, your levels of injury. Let's have number 13. What should the nurse include in the care plan for a patient with a T9 spinal cord injury who has a neurogenic bladder? Neurogenic reflexic bladder. Is it A, instructions, instruct the patient the Crede method, or is it B, teach the patient on self-catheterization, or is it C, catheterize after each voiding to assess for residual volume, or residual urine rather. D, assist the patient to the toilet every 2 hours. T9, spinal cord injury, neurogenic bladder. What would be appropriate this time? T9, spinal cord injury. What would be the best answer? If they have the spinal cord T9 injury, the correct answer here is letter B. Let me explain. The intermittent self-catheterization is going to be helpful in managing the spastic bladder by regularly emptying it in order to prevent incontinence. All right? Regular bladder emptying. Okay? Yeah. And another reason that this is also a good teaching because it will prevent incontinence, overflow incontinence. Now let's have letter D. What is in letter D? Assist the patient to the toilet every 2 hours. What do you think about the every 2 hours? It's not going to address, it's not going to help the patient because the issue of bladder emptying, again, The action itself is not going to resolve the issue of bladder emptying in response to the over distension. Again, the patient has a spastic bladder. If your patient is just going to the bathroom, there's not gonna be a resolution this time. They're just gonna sit or maybe stand into the toilet without any output at all because of the spastic bladder. It's not going to empty their full bladder. So this is just a waste of time. What about catheterize after each voiding to check for residual urine? Will you do that? After voiding, this is not going to prevent the incontinence in a reflexic bladder. All right, this is not going to prevent incontinence in a reflexic bladder. Incontinence, rather. After voiding, why would you do that? Catheterizing, that would be a lot of insertion there after they voided. I mean, why? The patient here cannot even void. So why would you do that kind of a statement? It's counterintuitive. The catheterization is actually done because they cannot empty their bladder. So that is why the statement itself is wrong. A, instruct the patient the Crede method. What do you think about the Crede method? This is only suitable for a flaccid bladder, not spastic neurogenic bladder. All right. Indicated for a flaccid bladder. We are talking about a bladder that is spastic, especially that we have this description right, neurogenic reflexic bladder. This is a spastic urinary bladder. It will not be successful. If we were going to teach the patient to keep pushing their bladder, that Crede method, it's not going to work. All right. So catheterization would be the best answer here in order to properly empty the bladder and also to prevent the incontinence. Let's have number 14. A patient with a C7 spinal cord injury has a weak cough and crackles. What should the nurse do first? Our level of injury here is C7. So the patient is manifesting a weak cough and crackles. What would you do here? Will you suction the nasopharynx? Or will you inform the healthcare provider? Or will you assist the patient with an abdominal thrust during coughing? Or are you going to encourage the use of an incentive spirometer every 2 hours? Guys, take note about the damage, where it exactly is happening. It's on the C7. So what would help this patient this time? If their cough is weak. All right, let me start rationalizing. Let me have letter D this time. If you answered letter D, incentive spirometer, you encourage the use of an incentive spirometer every 2 hours. What do you think about that? We know that it's going to be beneficial, but may not be immediately effective in this patient that has weak intercostal muscles. Guys, when you have a patient that has a C7 injury, the supporting respiratory muscles, especially the intercostal muscles, are not well functioning. They are weak in assisting the coughing action. They're not going to be effective in not expectorating, but actually creating or voluntarily have that cough. They will not be able to do that effectively. So again, incentive spirometer will only be beneficial to maintain expansion, but not about the coughing itself. Is abdominal thrust the same as assist cuff? Yeah, this is the correct answer. Assist with an abdominal thrust during coughing? That is the answer for this question. So what do you do here as a nurse? While the patient is having a weak cough, you will do an abdominal thrust to help support the diaphragm. It will help clear their secretions, because when you do the abdominal thrust, it actually will increase the pressure in the abdominal area, and this will help create that stronger cough. And this is a common maneuver that you should be doing to help the patient cough those secretions. All right, the correct answer is letter C. If you answered letter A, suctioning the nasopharynx, well, this is needed, right? If the coughing fails, you're going to need to do this if coughing fails. I ask about what should be done first, which is basically assisting them to cough with that abdominal thrust. Okay, so this is wrong. This is not the initial action. What about informing the healthcare provider? You're going to do this once you have done your other attempts in managing their airway. After you have done the abdominal thrust, after you had suction, and if still there's no response to those maneuvers or treatment, then you're going to have to inform the healthcare provider. Okay, so this would be our last nursing action in this scenario. Let's have number 15. What is suitable rehabilitation goal for a 30-year-old with a C6 spinal cord injury? Is it drive a car using a powered hand control? Or B, propel a manual wheelchair on flat ground? Or is it C, independently turn and reposition in bed? Or is it D, transfer independently to and from a wheelchair? 30-year-old with a C6 spinal cord injury. Rehabilitation goal. What do you think? What is a suitable rehab goal for a 30-year-old with a C6 spinal cord injury? Are you going to do A, B, C, or D? Okay, while waiting for your answers, I'm going to have to start rationalizing. Letter D, transfer independently to and from a wheelchair. Well, the word just independently. This is going to be difficult because this is going to require more advanced skills. This is not realistic. Patient here, again, will require more advanced motor skills. This is something that is not going to be appropriate this time. What about letter C? Independently turn and reposition in bed? What do you think about this? Independently. The word independently. Turn and reposition in bed. We know that the turning and repositioning independently is very challenging, again, because, again, the patient has a C6 spinal cord injury. The patient has what? Limited upper body strength. This is the main issue in this patient. They don't have the coordination to do this on their own. So they will not be able to do both C and D. What about letter B? Propel a manual wheelchair on flat ground. What do you think about letter B? Propel. What do you think? Propel a manual wheelchair on flat ground. What do you think? So for those patients that have C6 level injury, they can actually use their hands. That's available. They can use their hands to push a wheelchair on a very smooth, flat surface because of the partial hand function. Okay, still has partial hand function. So this is something that is still available in this patient. They will still have this motor function. Propel and manual wheelchair on flat ground. They can do it. And again, we are actually promoting rehabilitation into this patient. This is a possibility. If you had answered letter A, driving a car using powered hand controls, this is actually going to require more hand function, not just operating hand controls, right? And typically available at C6. So this is going not to be a realistic rehab plan for him, okay? It will require more hand function. Alrighty. Paraplegic, C6 injury. What do you think about the C6 injury? Going back into our photo. They're going to end up with what? The paralysis of the legs. There's also paralysis of the trunk. There's also paralysis of the wrist. But they will still have some function. They only have weakness of the shoulder and elbow. Yes, they are paraplegic, right? So don't forget about that. Yeah. They will have gross function of the hands. They will still have remaining function. But again, like you said, Mariama, the fine motor skills will be somewhat impaired this time. Let's proceed into the next question. Where are we at? Hypercalcemia. Where are we? Number 16. Yes, number 16. A female patient with a quadriplegia asks about her sexual health. Which statement shows that she understands her current sexual function? Is it A, I can't have sex until my catheter is removed? B, I can't engage in sexual activity but may not orgasm? C, I can't have intercourse because it raises blood pressure? And D, I can have sex but will be infertile. What do you think about this question? Which statement shows she understands her current sexual function? A patient with quadriplegia. Would that be A, B, C, or D? Let me try letter D. I can have sex but will be infertile. Do you think that it can affect the fertility of our patient? That is false. Patients can actually do some family planning around if you were going to give them the correct information. And so it doesn't really affect the fertility. This is wrong, okay? They can still plan on having a family because it's not going to affect their fertility. What about letter C? I can't have intercourse because it raises blood pressure. Will it? No, it's not known to impair them, okay? It is not known. Let's have letter A instead. I can't have sex until my catheter is removed. Well, there's really no need to remove the catheter for sexual activity, right? This is an overall generalized question about sexual health. There's no need to remove the catheter for a sexual activity, guys. That's a false statement. What about letter B? I can engage in sexual activity but may not orgasm. Letter B. We know that with a patient that has a spinal cord injury, they can still engage in sexual activity. But again, the issue here is about not experiencing the orgasm because of the disrupted nerve pathways. That's the reason why this is going to be the correct answer. I can engage in sexual activity, but will not have any orgasms. And the reason for that is because of the disrupted pathways. If you had answered letter C, I can't have intercourse because it raises blood pressure, it's not known to cause that one. No brain connection. Let's have number 17. I believe this would be the last test item. A patient with a T3 spinal cord injury and dermal ulcers reports a severe headache and nausea. What should the nurse do first? Is it A, check for fecal impaction, B, administer the prescribed antiemetic, or is it C, measure the blood pressure, or D, contact the healthcare provider? Your patient has a T3 spinal cord injury and now has dermal ulcers, complaining of severe headache and nausea. What you should be your first step? Are you going to do checking for fecal impaction? Or are you going to administer the prescribed anti-nausea medication? Or are you going to check the blood pressure this time? Or will you call the medical provider? What do you think? Let's have letter D this time. Contact the healthcare provider. Will you do that right away? Again, remember that you are supposed to check your patient, do initial assessment. So calling would not be, or contacting the medical provider this time would be not the first action. What about letter C? Measure the blood pressure. Severe headache. Remember earlier we kind of eliminated the blood pressure, right? Measuring the blood pressure, because there was another intervention that would have taken place. What do you think? Measure the blood pressure. If your patient really has a a headache and plus the nausea, what are you going to do here? Which would treat, or which assessment that can really pinpoint that the patient has hypertensive crisis? That is the question at this time. What would be that nursing assessment that can quickly assess that your patient is in a hypertensive crisis? And this is what we have in a patient with autonomic dysreflexia. Of course, nothing else but measuring the blood pressure, nothing else. You will not know the patient's blood pressure if you're just checking the fecal impaction. Or this one, letter B, administering the prescribed antiemetic. You're only dealing with the symptom, but not really figuring out if the patient is in a hypertensive crisis. What we need to do this time is an immediate identification if the patient is hypertensive. That would be quick to do, okay? Fecal impaction, this is delaying your treatment, guys, even though this is a good nursing intervention. But looking into the what do you call this? The urgency of the patient's situation, you would do something that can quickly assess the overall situation, which is the blood pressure itself, checking the BP. All right. Once you do that, if there is a PRN order for antihypertensive drug, maybe hydralazine, then you can give the medication right away. Then you're going to notify the medical provider. But if you are going to do letter A, checking for a fecal impaction, and then what's going to happen next? Yeah, will you do the blood pressure after? I'm not quite sure how your approach is going to be if you're going to select letter A first before blood pressure monitoring. And so again, select that assessment skill or action that will immediately identify the hypertensive crisis in this scenario, and nothing else. That's only letter C. Oh, there's one last. I guess this is the last for the day. A home care nurse notices a spouse doing tasks for a patient with a spinal cord injury that the patient had been doing independently in rehab. What should the nurse do? A home care nurse notices a spouse doing tasks for a patient with a spinal cord injury that the patient had been doing independently in rehab. What should the nurse do? Is it A, remind the patient about the importance of independence? B, tell the spouse to stop assisting with tasks? Or will you do C, develop a plan to increase the patient's independence with input from both? Or letter D, encourage the spouse's involvement in the patient's care? Well, welcome, Jocelyn. What will be your answer here? Our last item of the day. You have a very helpful spouse this time. That's good, right? But then again, there is a change in the level of independence in this patient. Previously, the patient was doing those tasks on his own. But by the time when he was transferred back to his home, now the patient's wife is doing a lot more. So what will you do to address this huge change? You don't want to keep this scenario going, right? Especially that the wife is doing a whole lot more. That's not going to help your patient this time if they're not allowed to do their own tasks. So what is it? Your best answer here, guys, would be letter C. You're going to have to develop a care plan to increase the patient's independence. Of course, you're going to involve the wife. They're going to be the main person for the support. So exactly do letter C. If you're going to select letter D, which is encouraging the spouse's involvement in the patient's care, then it's not really pointing out to her that the husband is not doing a lot more to encourage their independence. So basically, you're only encouraging the spouse to be much more involved. Okay, so that's why we are not selecting letter D. What about letter A? Remind the patient about the importance of independence. Just simply reminding is not going to address the dynamics between the patient and the wife. If you answered letter B, telling the spouse to stop assisting with the task, this is going to cause tension. Of course, if you are the wife and you are worried about your husband, you would gonna be pissed off, right? This is not going to foster a supportive environment if you're gonna tell the spouse to stop assisting. It's the unhealthiest advice that you would be giving to the patient's spouse. Eliminate that one. So we don't have anything else but letter C. Involve both and make sure that you are going to devise a care plan that would do more encouragement, that would allow the patient to do some more activities on his own to foster independence. And that's it for today. Again, thank you for your attendance. I hope that you're learning something from the short lesson, and I'll see you again tomorrow. And we have already posted our schedule for the next sessions. And so I'll see you again tomorrow at 9 p.m. Eastern Standard Time. And I'll see you soon. And I hope that you are learning. That's the goal for today. I hope that you are really learning. Okay, guys, bye for now and stay safe. Thank you.